more where I love to be. This is in the mountains, in the Rocky Mountains. And I spend as much time up here as possible. And I'd also enjoy sharing this with you, whether you like to hike, bike, ski, whatever you like to do. We'd love to have you. So today we're talking about virtual training. And this is a little video I'd just like to share with you about how can we learn to do things when we can't meet and take labs and join. And I think this is a great example.
Let's go. Whoa.
So obviously, COVID has changed our lives a lot and how we can work and train, but I do think these meetings have benefits. And I'm going to share with you a little bit of evolution of technique that's occurred over the last quarter of a century, even a little bit longer now, I hate to say, sort of dating myself, for where I really felt the morbidity of a thoracotomy incision was tremendous in small children and infants. I learned this during my thoracic fellowship, and so I started with using a muscle-sparing technique. And then as video-assisted surgery progressed, we kind of went through doing a mini thoracotomy and using some minimally invasive instruments to now everything we do is done using a minimally invasive approach. And that certainly is true for all congenital lung lesions. We do not do an open thoracotomy for any of these. I realize that's not possible in all places in the world, so please understand as I talk that I think you need to do what you can do safely in your community and your environment. But I think this should be what we all strive for, and it's part of what WOFAPS and IPEG stand for, is that bringing these techniques around the world so that every child has the benefit of this kind of surgery. So just to kind of define things, bronchopulmonary malformations are a spectrum of diseases. And they're all sort of tied in. And I'm not going to, so the most straightforward ones are foregut malformations, esophageal duplications, or bronchogenic cysts. We're not going to spend a lot of time talking about that, but certainly bronchogenic cysts come out of sort of the same sort of pathology. CPAMs, and the name continues to change, and it probably will change again during my career, but there's really from type 0 to 4. The two most common types are types 1 and 2, where you have single or multiple large cysts, where you have multiple smaller cysts, and that's the majority of cases, and really what we'll be dealing with. There are, type 3 and 4 are much rarer, and one thing I'm not going to talk about today is fetal intervention for these. There is a rare case where you have significant CPAM development, you have almost a solid-like tumor, you have significant mediastinal shift and high drops in the fetus. And in maybe 2 cases a year in the United States, if that, fetal intervention is warranted, but it really isn't part of what we're going to talk about today. But we do now diagnose most of these prenatally. And then there are pulmonary sequestrations, as you know, intralobar and extralobar, and then congenital lobar emphysema, which is a little bit different pathology, usually due to weak walled bronchi or bronchioles, and we'll spend a little bit time talking about that. But I sort of look at all these entities as just on a spectrum, and we approach them similarly. So just to start out, what are the known postnatal complications of a CPAM? And Tamir, if you could put this question up. Is it up? There you go. So if everybody wants to vote, I'll give just a second for everybody to get in there. Okay. Well, I think, we'll talk about this, but I think, everybody pretty much gets it. It's actually all of these. They can all have a significant impact, and that's why we choose to operate on these patients. And I know some people choose to just follow these patients clinically, and hopefully I'll be able to show you this morning why that is an issue. All right. All right, I'm trying to get out of here. Oh, there we go. So, why resect CPAMs? Why do we have to do anything? And there are many places in the world where they say we don't need to. Well, I'm not going to share all the literature with you this morning, but you need to know that there's a risk of infection, is documented anywhere from 20 to 45% in these lesions over the course of the child's life. There is definitely an incidence of malignancy, and this is debatable. It's probably higher than we think, but I think there's good documentation out there that it's anywhere between 2 and 10% of these lesions either are misinterpreted and are actually pulmonary blastomas, but not thought to be, or can go on to develop an adenocarcinoma and are rarely a squamous cell. And so that's for real. And then I think we're also now looking at KRAS gene mutations, which are much more common than we thought, and also are associated with a high incidence of malignancy. And this is a paper that was published by one of our distinguished faculty today that shows that even in these patients who are young and asymptomatic, that if you actually look at their microbiome and you look at specimens of the lung, that they actually are harboring significant infections, and that up to half the patients or over half the patients can have significant bacteria. And these are asymptomatic patients. And one of the things that I'll talk about today, why I choose to operate when I do, is that I think even these asymptomatic patients have low-grade chronic infections going on, so that if you operate on them later in life, that's relative terms, that often you get in there, and even though they've never had a pneumonia, never been clinically symptomatic, that there's significant inflammation, adenopathy, and other things when you operate. And so I choose to operate on these patients younger. So what's the appropriate workup postnatally for a CPAM? Which on prenatal ultrasound, so again, we see most of these patients prenatally now, we get to talk to the families, and often it will appear that the CPAM will regress on prenatal ultrasound. So once the patient's born, what study do you get to determine whether the CPAM's actually there or not? Okay. All right. So, it looks like about half say CT scan, and then a smattering of other cases. And, so my personal feeling is that you have to get a CT scan. I've seen many patients who have come to me from other institutions. They were diagnosed prenatally with a CPAM. They then were evaluated at their home institution, and they either got a chest X-ray or an ultrasound, which looked normal. They said, okay, you don't have to worry. And at a year of age or 2 years of age, the patients show up with a significant infection and then are diagnosed with a CPAM. I just don't think MRI is sensitive enough. And some people are saying, now you can use MR to evaluate these prior to surgery. And there's some reasonable papers out there, but honestly, I want a very detailed look. And I also think it helps me plan the surgery. And so for me, at least, all these patients get a CAT scan, and we'll usually get that somewhere between 4 to 8 weeks of age. And we get them early again, because I choose to operate on these patients early. So workup. So again, all these patients get a prenatal ultrasound. We honestly don't often get a prenatal MRI because it doesn't change what I do, how I'm going to manage the patient. I know a lot of places are getting prenatal MRIs for everybody, but I tend not to get a test unless it's going to change what I do. So if it's a really large CPAM, we might get an MRI, but otherwise we just sort of wait for the baby to be born and then evaluate that. All those patients, once they're born, do get a chest X-ray if they're asymptomatic, just to make sure there's not something grossly wrong that we're missing. And then I'll usually let the patients go home and bring them back in for a CT scan between 4 to 8 weeks of life, and then we'll proceed from there. Again, we don't really use MRI, and if thoracoscopy is always an option to evaluate these lesions. So what are the goals of surgery? Well, it's to remove harmful or potentially harmful lesions. We want to allow for maximal compensatory lung growth. And again, I think the earlier you do this, the better compensatory growth you have. And I tell patients, even when we're performing a lobectomy on these infants, that they will basically have normal lung function, and that's been shown to be true. We definitely want to minimize the morbidity of the operation. And then, I think a lot of places choose not to operate on these is they're trying to evaluate the risk versus benefit ratio. I feel, at least in our hands, using these procedures minimally invasively, that the risk-benefit ratio is very much in favor of taking these out. The principles of the surgery are, one, you have to do an anatomic dissection and avoid mass ligatures. And I always cringe when I see a video, and I see them frequently, where people have chosen to do a lobectomy in an infant or a small child, and they simply take an endoscopic stapler and put it across the greater fissure and mass ligate the artery, the bronchus, hoping that they won't injure something. And that's extremely dangerous. You have to see the structures individually, and you have to ligate them and divide them individually, no matter what technique you use, but it can't be a mass ligature because eventually you're going to get in trouble. You have to understand the relationship of the bronchi and the vessels, and you need to make sure it's very easy, especially in a smaller child, to injure the bronchus to the middle lobe if you're taking out a lower lobe, because sometimes it comes out lower and in a different area. And so you have to really understand the relationships, see where it is, and make sure you don't injure it. For sequestrations, I always identify the systemic vessel first. And if we're doing a lower lobe, I always look for it first, even if I don't see it on CT scan, just to make sure I don't miss it, because the consequence of tearing that vessel, as you know, is very significant. Understand the anatomic relationships. And then in most cases, I do a complete lobectomy, but we'll talk about that a little bit. So what is the advantages of using single lung ventilation and thoracoscopic lung resection? We're getting into technique a little bit more. Tamir, if you could put up the next question. We stumped everybody on this one. There we go. All right. Well, it looks like most people got it. So the advantage of using single lung ventilation is really for the surgeon. It's a quiet operative field. In fact, you probably get an increase in end-tidal CO2 because of single lung ventilation. Oxygenation actually in most of these patients is fine. That's not a problem. It's usually a higher end-tidal CO2. And so you need to work with your anesthetist to get them to increase their respiratory rate and tidal volume a little bit to help blow off that CO2. But a CO2 in the mid 40s during one of these operations is not unexpected, and it's also not dangerous. But really what we're trying to do is aid the surgeon so that he can do the operation better and quicker. And so we tend to use single lung ventilation and valve trocars. And then I also use CO2 insufflation as well to help collapse the lung, because it's hard in an infant or small child to get perfect single lung ventilation because they're too small for double lumen endotracheal tubes. And in fact, what we choose to do in most of these cases, because it's the easiest thing to do, is to do a main stem intubation of the contralateral bronchus. So if we're doing a right lower lobe, we put the endotracheal tube down the left main stem bronchus. And this can usually be done blindly, honestly, just by some gentle manipulation. But if not, then you can always do it with a bronchoscope. But, you know, unfortunately, our anesthetists don't have a lot of practice at doing lung isolation. They can often take longer to put in a bronchial blocker than it'll take you to do the case. And most of these patients tolerate a main stem intubation without problem. So this is our preferred way to do it. If they can't do it, you can do it with just a tracheal intubation and CO2 insufflation. It's just the field is a bit brighter. And this is just to show you. So on the left is a case where we didn't have single lung ventilation, and you can see the lungs inflated. It's hard to visualize things. And on the right is where we have a main stem intubation of the left main stem bronchus, and you see the lungs completely quiet, even though we have big cysts. The anatomy is very easy to see, and it makes the surgery much, much easier. So I really do think that this benefits the patient because it makes the surgery easier. So again, lung resection technique, you need to use meticulous dissection and hemostasis. A little bit of blood gets very difficult to see in this small space. If you need to create space. So if you have big air or fluid filled spaces, you need to get rid of those so that you have room to work, because the chest cavity is fixed. It's not like laparoscopy where we make a bigger cavity. I do all these patients working from front to back. So when I do an open thoracotomy, I have always stood at the back of the patient, but when I do a thoracoscopic surgery, I always stand at the front because there's more room between the chest wall and the mediastinum. And so I have more space to work. Again, you have to understand the spatial relationships of the pulmonary anatomy and avoid mass ligations. And you're going to get sick of hearing me say that. So what do we do in terms of, you know, vessel and bronchus management? Well, you can suture ligate, but honestly, it's very time consuming. You know, and I think there are better ways. You can use endoscopic staplers and endoscopic clips, and they have their place. But really what's revolutionized for me, pulmonary surgery, was vessel sealing devices. And I like vessel sealing devices that will seal the vessel, but not divide them until I'm ready. And so I like the ligature or the Just Right stapler. I should, or it's now Boulder Surgical, and I meant to put a disclosure slide in, but I do have a relationship with Boulder Surgical. I'm the one of the founders and the chief medical officer. But this for me has revolutionized what we can do in terms of operating, and I'll show you why. So the room set up for a thoracoscopic lobectomy is this. Again, patient in lobectomy, we always have the patient in the lateral decubitus. The surgeon and the cameraman, the assistant, are on one side. Depending on the lobe, the assistant might be above or below the surgeon. The monitors are directly across, and the scrub nurse is directly across from the surgeon as well. And this is, I think, the best setup. And then trocar placement is really key. And I think this is where a lot of people get into a lot of trouble. So here's so this is a patient, we're doing a left lower lobe. So the patient, this is the patient's front, the nipple is over here. This is the tip of the scapula. So my camera port is just below the tip of the scapula, and then 1 or 2 centimeters anterior, so that I'm overlooking the fissure. And I think most people, if they make a mistake, it's that they put the camera at the tip of the scapula or slightly behind. And then my 2 operating ports are actually in the anterior axillary line. My right hand is just above the diaphragm, so I look inside. And this will be my 5mm port where I can put in a stapler or clips and bring out the specimen. This is a 3mm port. Again, this is an infant, and I use really certainly up to 10 kilos. I use just 3mm instruments and 5mm instruments for these. And so my right and left hand, and I try to get my right and left hand at 90-degree angles to the area where I'm doing most of the detailed work, which is going to be in the major fissure. If we're doing an upper lobe, we shift everything up about an inner space. So this is, just to show you extra lobar sequestrations. This is a very old video with old technology, but these are, good procedures to start with because there's basically just one blood vessel. This is the old ligature, the LS1000. This isn't made anymore. And you can see there's just one vessel coming in right here, directly off the aorta. The thing you need to be aware of is that about a third of the time, or maybe even a little bit more, these vessels actually come off the aorta, but in the abdomen and come up through the diaphragm. And if you lose control of this vessel, the patient can bleed to death before you can do anything. And so it's very important to be very careful in mobilizing it. And here we're just using, I wouldn't use this technique anymore because I have other options, but we're just getting good length on it. And then we're using clips. And I think using clips on a vessel like this is fine. You know, it's depending on what sealer you use. The 3 millimeter vessel sealer will seal vessels up to about 5 millimeters. The 7 millimeter, the 5 millimeter vessel sealer will do about 7 millimeters. This is a large vessel, but if you're going to put clips, make sure you put a couple. And then always be sure before you put the clip applier on the vessel that you load the clips. And one of the things I don't like about clips is that they can come off. But here you can see we're just taking it out. So that's a nice, easy case. This kid goes home actually the same day, doesn't need a chest tube, and it's pretty quick and easy. Now this is one of the largest sequestration vessels I've ever seen. This is an intralobar sequestration. And here you can see we're using the 3 millimeter vessel sealer. But this vessel is so large that the clips won't fit on it. And I'm actually helping the surgical fellow in New York do this case. And I'm watching, sort of having a heart attack as he's trying to get this clip applier on there. And I'm waiting for him to tell me that he doesn't think it's big enough, which he never did. But you can see the clip is preloaded. And we're just going to put on a clip. Well, that clip's okay. But then he puts on all these other clips. And none of them actually cross the vessel. And this is extremely unsafe, and I don't like it. And so about this point, I kind of take over. And you'll see why I don't like clips. So they're one that actually looks like it's scissored, but you can also take them off. And clips can fall off. So I'm not crazy about clips. I do use them sometimes. But this was one of the first cases where we had the 5 millimeter stapler available. And so we had proximal control with the clips. And so I brought in the stapler to use it. Now, whenever I use the stapler on a major vessel, I always make sure that I have proximal control because I assume that anything can fail. So in this case, I had clips proximally, so I grabbed the other side of the vessel. But if I didn't have clips on it, I would for sure have put my Maryland on the proximal part of the vessel just in case the stapler failed. That I've not had that happen, but you have to anticipate failure. The key to safe thoracic surgery is anticipate failure, and so that if something bad does happen, you're in an ability to control it. So again, these are the techniques I use now. So for vessels, this is vessel sealing, and this is the technique I use. I basically make two separate seals. So you see I make a proximal seal and a distal seal, and I look for that white bubble between the seals. The seals should be at least 3 to 4 millimeters apart. And then I cut part way between the vessel. And when I see there's no bleeding and a lumen, then I can cut the rest of the way. And the advantage of this technique, as opposed to using something like the harmonic or something that seals and cuts at the same time, is that, again, everything fails. So if the seal for some reason fails, I'm able to see some bleeding before the vessel separates and retracts. So I still have control, and I can get back in there with either my sealer, a clip, whatever you want to do. And I realize that many places in the world don't have the 3 millimeter sealer yet. You can do this with a 5 millimeter vessel sealer, but ideally you use it. But I do not seal and cut at the same time unless it's a very small vessel, because if the seal doesn't work, then you're in big trouble. The other thing I don't do is I don't seal one side and I don't put clips on the keeper side and then use energy on the other side, because the energy will change the complexion of the vessel. And I've seen 3 cases where there was late bleed because the clips sloughed off, because clips were used on the keeper side and energy on the other side. And then 24 to 48 hours, those clips just fell off and there was an open lumen. So either use clips on both sides or use energy, but don't combine the two. So this is talking about creating space. Here you can see a large CPAM. How would you ever do this thoracoscopically? There's no room to work. So the first thing I do is I go in there and I collapse these cysts, and I use the energy device to do this. And you basically, it's nice when you have big cysts like this because it's easier, but we'll go in and you can see we're just going to pop the cyst. And so we use the energy to collapse the cyst. And then suddenly I have a huge amount of room to work. So even though this is a very small baby, this is a, under 4 kilo baby, newborn. And now I can see, and I'm able to identify where the fissure is or should be, and I can work in order to do this lobectomy. But that's the key. And if it was full of fluid, then I would remove the fluid as well. So this, I'm just going to run through this. This is a pretty straightforward. This is a right lower lobe CPAM. You can see the first thing I'm doing is taking down the inferior pulmonary ligament. And I do that to make sure there's not a sequestration vessel and also to expose the vein a bit, so in case I have to come under. And then we're going to go right into the fissure. So this is a pretty complete fissure, but you can see it's somewhat incomplete anteriorly. And so I'm going to go across it here using, I like using vessel or tissue sealing for doing this. And so what I'll do is I'll just make 1 or 2 seals, and then I'll either cut in the middle of the seal or make 2 seals and cut between them. And you can see that it's a relatively bloodless field, and I'll just tell you that these patients have no air leak. And we'll just march across, we're going to march across the fissure. And so this kid was 3 months old, but you can already see that, look at these enlarged lymph nodes. So this kid has been completely asymptomatic, but there are already abnormal lymph nodes because of chronic inflammation. And so this makes the surgery more difficult because they tend to be sitting right on the blood vessels, and it makes it harder to dissect them out, and you can get into more not so much troublesome, but annoying bleeding. It kind of makes it, it distorts the field, a little harder to see. But here you can see I'm working through and I'm just dissecting, completing the fissure posteriorly, and then I'm going to go ahead and seal. And what I do is I look for the pulmonary artery as I open up the fissure. And so here you can see the pulmonary artery to the lower lobe as it traverses the field. We've got these large lymph nodes here. And then I'm going to look for the segmental vessels. And in most kids, and again, I'm operating earlier probably than most, I like to get the vessels at the segmental level. So there's the superior or apical segmental vessel to the lower lobe. Here's the main basal trunk. And we have good exposure. So now what I'm going to do is I'm going to go ahead and dissect out that apical segment. And because I know that the bronchus sits right behind it, so you have to remember that the bronchial anatomy is the same as the arterial anatomy, especially in the lower lobe. And now you'll see this technique of making a proximal and then a distal seal. And then I'm going to just, again, I don't use a device that seals and divide. And this is pretty much in real time. This is a minimally edited video. And for those of you who want, these videos are available. You can see I can see the lumen, and I see there's no bleeding, and now it's safe to cut. And these videos are available on the web. A lot of them are on YouTube. They're also available on the Boulder Surgical or Just Right Surgical site. You can go and watch them for free. And these are detailed videos that are that I narrate, and they last anywhere from 10 to 20 minutes. But I think and I've tried to put one of each lobe on so that you have it there. And now you can see the segmental anatomy that's showing up. And now we're going to just complete the fissure a bit. Same thing. I'm just going to speed through this a little bit. And now I'm getting, so again, here's the basal trunk right here. And you can see how clear the anatomy is. And because I have the scope in about the mid-axillary line, I'm able to look down on my instruments and look forward just as I would in surgery, as opposed to having the scope too far posterior where I have to look back on myself, and that can make the surgery extremely difficult because you're working in a paradox. So now we see all the segmental basal trunks, and we're going to take these separately. The other option is to take it right here at the main basal trunk, and sometimes if the sonometer, I'll use the 5mm stapler to do that. You can also suture ligate it. But again, the beauty of sealing is that you can do it with one hand, and you can then divide and make sure that everything's safe. So I'm going to progress across and take each of the basal trunks in this fashion. And I just operate with 3 ports. If you need a 4th port to have someone retract for you, that's fine. I'm so used to operating and retracting but for myself, so I operate one-handed. I retract with one hand and then I dissect with the other. I'm very comfortable with that, but if you need somebody in there so that you can have 2 hands right in the operative field, that's fine. Just put in another port. I just find it gets in my way, but that I have a lot more experience, so it's easier for me to do this. So we're just going to plug along, and you can see we're getting the last of the basal trunks. There's one more, and it's just very progressive, and we just keep moving. There's nothing, we're not trying to be fast, but this is actually very efficient surgery, and this operation took just about 30 minutes because we're just methodical. We know what we're doing, we just keep progressing. But I think you should be able to perform most lobectomies in under 2 hours. And once we've taken the artery, then we know that the bronchus is right behind it. So here you can see I'm getting the anterior basal trunk right here, and I'm bouncing off the bronchus because the bronchus follows the same trajectory. And we're just going to keep moving. Oops, sorry, that wasn't good. And now we've worked through that, and now we're going to dissect out the bronchus. And the last bit, I took the rest of the trunk with the stapler. I didn't show that, but now I've dissected out the bronchus. Sorry. And then the inferior pulmonary vein. And we can take that with a single application of the stapler. So I apologize that we flipped, I'm going to go back. It flipped on me. I'm going to show you that next. That was somehow we got, so there's all the vessels. Now we're dissecting out the bronchus. I apologize, got to the next video, which is the left lower lobe. That's why it looked different. So now you can see I'm dissecting out the superior segment of the lower lobe. So remember, there was an artery that laid right over that. That relationship is almost always there. So once you find the artery, you'll be able to find the bronchus. And now we're going to just dissect it out. And now you can see I've dissected it out. And again, because I have the 5mm stapler, I'm going to use it. If I didn't have the stapler, I would simply use clips for this. I used to cut and sew it, but 5mm clips actually work quite well in the bronchus. But the stapler, I feel more confident in. They don't come off. If I didn't have it, I would just use a clip as long as the bronchus fit in it all right. And then here's the main trunk, the basal trunk, and we can take all the basal branches together. And here you can see it dissected out, so we're very clear. The only thing you have to be careful, I used to do artery, then vein, and then bronchus, but because thoracoscopically, if you just go from front to back, it actually lays out much better to take the artery, then the bronchus, and then the vein. And again, the stapler makes this very easy because you can seal and divide the bronchus all at the same time, and it just makes it easier to get more length on the vein, and you'll see that in a minute. So we've created a nice space here, again, knowing that the vein is lying behind the bronchus and taking care not to injure it. And here you see the stapler coming in. We're well away, the middle lobe bronchus is over here, so you can see I'm well away from that to make sure I don't compromise the middle lobe. And we'll seal and divide it. And then the last thing is simply to take the vein. And here you can see the inferior pulmonary vein. We've already done the dissection down here, and now we're just going to get length on the vein. And the key here is I use the stapler almost always on the inferior pulmonary vein. But again, like I told you, I always oh, sorry, did it again. I always make sure that I have proximal control. So here you can see we're getting some length. Sometimes I'll have to take some small branches with the sealer just to get some more length. Getting a little more length. Now you can see that see how now we have a good length of the vein. And so again, you want to be at least a couple centimeters away from the pericardium, because if something goes wrong, you want to have the ability to not lose control and not have this retract and get bleeding. So I'm putting the stapler on. Now, if I didn't have the stapler, I would dissect up into the lung further, and I would get the vein where it bifurcates. And I would take the vein with sealer, or you could, if you want to ligate. Now you can see I have proximal control. This is what I mean by proximal control. So I fire the stapler. I can look at the staple line. If I'm happy, then I can let go, and you can see we have a great staple line and we're done. Now this is just a quick video that shows doing left lower lobe. And this is a case that we're going to use just completely. Again, this is a 2-month-old baby. Again, you can see these enlarged lymph nodes. In this case, the inferior pulmonary artery, lower lobe artery, comes through the fissure as one main trunk. And so in this case, I can take it all as one. And again, I'll use the 5mm stapler. Now, I do not believe you should use an endo-GIA in patients, certainly who are under 5 kilos, and I really believe 10 kilos. It takes up too much space. You can't see what you're doing, and you're going to injure something. So if you don't have a 5mm stapler, then just use vessel sealing or suture ligation or whatever you do. So you see there, we took the artery. Now we're going to do the same thing. We're going to dissect out the bronchus. Again, just coming straight through the fissure, going layer by layer. There's the bronchus. Get behind the bronchus. We're going to apply the stapler. So this is because the anatomy was so good in this child, and it was so, it was so easy to see. There was no fissure. We were able to use the stapler, which saves a lot of time. This surgery took about 20-25 minutes. And here you see the inferior pulmonary vein. And again, we have a good trunk. I'm able to get proximal control. And again, this child weighs about 4 kilos, and we're done. And then operate before they become infected. This is what happens. This is a patient who was a few years old, had multiple pulmonary infections before the kid was ever diagnosed with a CPAM. So I think that's really key. As far as an incomplete fissure, I like using vessel sealing, tissue sealing for doing it. You can use cautery. Some people, this is really, I think, the hardest thing for surgeons. When there's a really incomplete fissure, they're just not comfortable. And the key is you just have to go through the fissure layer by layer until you find the first branch of the artery. Once you do that, then if you stay anterior to that, everything's safe. But I think this is the hardest things for people to learn. So these were our results up until May of last year. We've now done about close to 600 lobectomies. The mean operative time is just under 2 hours. If I'm taking a trainee through it, it's a little over 2 hours. The very low complication rate, intra-op complication rate, chest tube duration, we usually get these out the next day, and the mean hospital stay is 2.2 days. This is a subset of those patients that we published, and these are patients under 5 kilos or 3 months of age. The mean operative time, you can see, goes down significantly, and the average hospital stay also goes down. So I think it's easier, assuming you have the right instrumentation, the right anesthesia, and the right team, it's much easier to do these patients when they're small because the vessels are small, there's no inflammation. It's just much, much easier and safer. So when to operate on prenatally diagnosed CPAMs. This is a question, Tamir, if you want to put it up. at birth, 1 to 3 months, 3 to 6 months, 6 to 12 months. I should have asked this question before I gave the talk and then after. So I think, yeah, I mean that, you know, I think most people, I think before 6 months is great. We like to do them young, you know, right around 3 months. I would, you know, we can still do them from 6 to 12 months, but I just think the operation becomes much harder. This is just there is evidence that there's significant, you know, compensatory lung growth if you do get the malformation out. And I think it's important, the earlier you get it out, the better the compensatory lung growth. And then a lot of people say, you know, just watch these, it's not a big deal. So I showed this, so that's the policy in England at a lot of institutions. I showed this case there. This was a prenatally diagnosed CPAM. The child presented with a pneumonia. I asked the consultants in the meeting what they would do. They said, we just treat with antibiotics, continue to watch it. And this is that child 3 months later. So this was a pleural pulmonary blastoma that was undiagnosed. And instead of having a simple thoracoscopic globectomy, this child had a massive tumor that required a major surgery. Luckily, the child's done well, but I just don't think we can tell, and I think we should get these lesions out. In my personal experience, I've seen 5 unsuspected malignancies. I've seen 4 of them were pleural pulmonary blastomas and 1 adenocarcinoma. But again, we are identifying more of these KRAS mutations. I'm going to kind of skip over this. We are, just to say that we are doing some segmental resections in certain cases where I feel that the disease is really limited to a certain segment. You know, and the best ones to do are like the apical segment of the lower lobe or the lingula. I've done about 45 of these now. But when I do this, I always have a follow-up CT scan at a year. And this is a recent case we did where this child came to me from another institution, prenatally diagnosed. And then it looked like initially they were told it was a CPAM. Then the surgeons there said, well, maybe it's a CLE. And the chest X-ray and CT scan at 3 months of age showed a CT in the lingula. And for those of you should visit, this will be shown at the IPEG session later this year. But I'm giving you a little teaser here, but we did a lingulectomy and preserved the rest of the upper lobe. So just to, you should all, this is how I feel after. Anyway, hang in there. I do think imaging will get better and help us decide what parts of the lungs are affected so we can do more segmental resections. But again, I can't recommend that to everybody. And then anytime I give a lung talk, I always show this photo. This was an operation I performed in Madrid in 2004. It was the first thoracoscopic lobectomy done there. This is Teresa. And I was invited to operate on her. And her mother is so grateful that every year on the anniversary of that surgery, she sends me another picture of Teresa to tell me how she's doing. Now she's a beautiful young teenager who obviously has significant lung capacity because she plays the flute, she's a gymnast, and it really does make a difference. So I'd like to thank you all for your attention. I'm happy to answer any questions. And I appreciate you all tuning in. And please feel free to contact me at any time if you have any questions or videos. And again, most of these videos, as well as many others, are available on the web.
Thank you so much, Steve. Really outstanding presentation and experience. I'm sure everyone has enjoyed, and no one from the audience could leave. On the contrary, it's keep on increasing the number of audience joining us. So thank you very much for a wonderful presentation. I'm sure Holger and Ciro are ready with some interesting comments and questions. So,
okay, hold on 1 second. I need to feed my dog.
Okay.
Please, Holger, do you want to start with the discussion?
Okay.
Yeah, Holger, unmute yourself, please.
Okay. However, I can start. Before
Okay.
starting reading the chat, I have a questions for Steve about telementoring. As you know, with decreasing resident experience in thoracoscopy during training and the constant evolution new surgical techniques, surgeons and young surgeons above all are at risk of complication during the early part of their learning curve. For this reason, mentorship by experienced surgeon may mitigate and lower this kind of complication. Do you think that telementoring can play a role during the learning curve in thoracoscopy?
Yeah, absolutely. So I think there's two pieces to that. One is, you know, the more you see, the more, the better you'll be able to deal with what you find surgically. So I think there's a couple different ways of telementoring. One would be that you or I are doing a case, for instance, because there aren't that many thoracoscopic lobectomies, wouldn't it be great in Italy if every time one was done, that we were able to broadcast that so every trainee in Italy or around the world could watch the case and learn as we do that. Then I think telementoring, you know, being able to, why would you not have the most experience you could in the OR at any one time? And so having an experienced thoracic surgeon be there virtually in the case to help guide the surgery along can help solve problems and complications. And I've had that experience where I've been able to stop surgeons from doing something that would have caused damage to that child. So I think it definitely helps. The problem with telementoring is that I think you have to have some relationship with the surgeon. One, you need to know that they actually have the skills to do the case. And two, you have to have a relationship so that if you say stop, they stop until you know, and so I don't want to telementor somebody who's going to do whatever they're going to do, whether I'm there or not. And so that's kind of the problem. And then there are all sort of medical legal issues, but absolutely. I mean, why wouldn't you have, you know, why wouldn't you have Sammy on a difficult undescended testicle case? Why wouldn't you not have Sammy, you know, beam in to tell you, this is where you need to put the stitch. This is how you need to get length. Or, I mean, for any, you know, unusual procedure.
Thank you very much. I think it's important telementoring above all in post-COVID era. I think telementoring have to be developed. If Holger agree, I can read the first two questions from the chat and then he can continue. There is a lot of interesting questions. There is a question from Farid Alagi, and the question is, in case of uncontrolled bleeding, clips, ligation, which is better for you, Steve?
If you have uncontrolled bleeding, open the chest.
Yeah.
Don't wait. Don't screw around. I mean, as soon as you feel you've lost control and visualization, you have to open the chest. So, you know, maybe I will, if you have a great experience, you can try to, you know, maybe regain control. But as soon as you feel you've lost control, you have 20, 30 seconds to get in there and control it. So I think what you use, so if you have some bleeding, what you use really depends on the circumstance. You know, first get control with a clamp or, you know, something to control the bleeding. Sometimes, often it's hard to get a clip on because of the angles. You know, I think vessel sealing works. You know, if you need to, you may have to suture. It just depends on your comfort level, your technique, your ability. But if it's uncontrolled, open the chest so you can get a finger in on it.
Thank you very much. Second question is from Pediatric Surgery Department of Red Cross Hospital. The question is, how many arteries and veins do you encounter? Is different or is a constant number?
Yeah, again, I mean, the anatomy is relatively consistent, even in these anomalies. So, you know, but what you need to know is that the lower lobe has 5 segments, and that's fairly consistent. Exactly where you'll encounter them depends on where you're dissecting, whether you take it as 5 separate segments or you take it as a complete trunk depends on the size of the child, the anatomy, what you do. So it's variable, but the basic concepts of, you know, how many segments there are to a lobe, that there's an artery that goes to each segment, but that it then bifurcates, that there's a vein that accompanies that, and a bronchus are relatively consistent. So you can't say you're going to encounter, you know, if someone's doing a lower lobectomy and I'm helping them, I always ask, how many segments are there? And they need to be able to tell me 5. They need to be able to label them for me. But it may be that we take the apical segment and the basal trunk, so we only encounter 2 arteries, as opposed to if the trunk's really big and we're not comfortable, we might dissect further into the lung, where we'll get each of the basal segments separately, and that's kind of what I tried to show.
Please, Holger.
Thanks. I think, Steve, on behalf of the audience, it's always a privilege to listen to you, not because of the finesse, yes, because of the technical details, but also, I think, because you're giving us some of the tips and tricks that save us from trouble, get enough length, how to deal with the vessels. So again, one of these super valuable talks to me as well. Thanks. Let's follow on this line of lobes and anatomy. You've beautifully showed the lower lobes. Which other lobe would you prefer before going to the middle?
Well, I think, you know, the lower lobes are the easiest. I think the hardest lobe is probably the right upper lobe, just because you have to get through the minor fissure, and that may or may not be significant. The second hardest lobe, I think the upper lobes are the hardest. Left is easier than right. And we didn't have time today, but if at some point in the future you'd like to do another, I'd be happy to go over the upper lobes and middle lobes. But I think, you know, the key with the middle lobe is, again, you need to develop the minor fissure, and then you need to understand where the arteries and bronchi come in the vein. And so the middle lobe artery has 2 branches, and they come in right sort of at the posterior aspect of the middle lobe from the top. So you have to open the fissure gently to identify those structures and then preserve them. So it's just being comfortable with the anatomy.
And one last thing, a question about this matter, the upper lobe, what's the death zone, the D2, the A2 area, which you keep teaching us?
Well, I think there's a couple things. The lower lobe's easy because everything that goes south of the fissure, you know you're going to take. But it can get very confusing in the upper lobe. And so I think each step is difficult. I usually approach the arteries at the apex of the lung first. I like to work from the top down, so I'll take the superior branches first, then I'll come around the front, and actually often take the superior pulmonary vein next, and then come into the fissure, and there's usually 2 branches of the artery that come through the fissure and come back up into the upper lobe. And it's also easy to get confused about where the bronchus is coming off. So when I do an upper lobe, I try to, and even a lower lobe, but especially an upper lobe, I hold it up so that it's kind of like a popsicle on a stick. So I can see that bronchus going just to the upper lobe. But it's easy to get disoriented and injure the bronchus, you know, the bronchus intermedius. So upper lobes are just much more difficult. You have to be slower and more cautious and really make sure everything's going into that upper lobe.
Cool, thanks. A question from the audience concerning technology again. 5-millimeter hemolocks for big vessels and bronchi, what do you think?
I think they're fine. I think you use what you're comfortable with. The thing about the hemolock, I have seen a hemolock come off, but also because it has that lock on the end, you need to make sure that you're completely across the vessel, because if you clip that down in the middle of the vessel, you could tear it. So just make sure you're completely around it. But I think, you know, if hemolocks are what you have and what you use, I think that's fine. And, you know, again, if you're struggling, you know, put a suture, ligate the vessel at the proximal end, so at least you have some control, and then use whatever other technology you have to try and work around it.
If Ciro is okay, I'll go for one last question. Interesting question, comes from Raman Mitul. Now he's asking, Steve, are your patients under regular neurological follow-up? And if yes, have you detected any abnormalities?
So, you know, the answer is no. I mean, we have done NIRS testing now, you know, looking for evidence of hypoxia. All I can tell you is that clinically they have, you know, at least subjectively, they have no deficits. We've had no significant hypoxia during the surgery. Again, I think these children can tolerate end-tidal CO2s, you know, in the 40s and even low 50s without any problem. If you want, you know, so I don't think it has been an issue whatsoever. Okay. I understand the concern. If you all go to my Facebook page, you can see I just had a 9-year-old boy who I did a thoracoscopic CPAM on 9 years ago. It was his birthday, and his parents had told him about his surgery and the hospitalization. They had come to me from another center. We did him when he was 6 months old, and he had all his friends give him money for his birthday, and he donated that to our hospital foundation.
Well, that's
so
sweet.
maybe that means he is neurologically impaired. I don't know what 9-year-old does that, but
No, that was sweet. Ciro, would you like to continue? Ciro?
Yes, thank you very much. Steve, is always a pleasure hear this very interesting lecture from you. I have another question. As you know, in the last 20 years, probably we have a huge development of new techniques and new instruments in the field of pediatric minimally invasive surgery. This process has resulted in a new and unique partnership between pediatric surgeon and industry. I think is important to develop new things. I would like to know your opinion about this partnership.
well, that's you're probably asking the devil in the details about that one. I mean, obviously that's been very important to me.
Yeah.
There is no way that we could do what we do today without companies like Storz and other companies who've taken an interest in minimally invasive surgery. Boulder Surgical or Just Right Surgical was a company I helped start primarily because we couldn't get the large companies, you know, Medtronic or whatever variation it was, or Ethicon, to make instruments that were small enough for our patients, basically vessel sealers and staplers. The problem with that, honestly, is that the reason they don't do it is because they consider our market to be too small. That, you know, for them to take on a new device, a new project, they have to be able to convince their CEO that it's $1 billion market. And, you know, nothing in pediatric surgery is $1 billion market. So it's hard to get companies to invest. Some have. I mean, Mrs. Storz has made a huge commitment to pediatric MIS. Boulder Surgical, you know, Just Right, our commitment is to pediatric MIS, but we're, you know, the problem is that people, and many places in the world, you know, they can't use the devices. They're too expensive, and I understand that. But if we don't push and support companies that are willing to make instruments that are specific for pediatric surgeons, if we just say we'll use whatever the general surgeons are using, we'll use instruments too big, then no company is going to invest in pediatric surgery. And so I think we really have to support these companies so that they, you know, they can make the instruments we need, and eventually the price points will come down, but it's very important. And unfortunately, pediatric surgeons for a long time have just sort of taken a back seat to our adult surgeon colleagues.
Yeah, I agree with you. I think is extremely important because above all, our small instrument have no market compared to the adult instruments. It's important to develop this partnership. I agree with you. Another interesting question asks for diagnosis from Red Cross Hospital. Why do you prefer CT scan over MRI in diagnosis? Is that to avoid general anesthesia needed for MRI, or because do you think that MRI is inferior to CT scan in diagnosis?
So I think MRI, it's both, but I think MRI is inferior. I realize And the truth is, with the high resolution CT scan that we give these children, you know, it's similar to being out in the sun in Colorado for a day. So the radiation is minimal, and I get a much better detailed picture that can help me plan the surgery. Also, if the lesions are subtle, I think it's much easier to pick them up on CT than MRI. So I just don't think, and I know there's disagreement about this, and I think that's fine. And I think perhaps someday MR will be sensitive enough. But for me, I'm getting one study to really help me decide and plan a surgery. And so, you know, I think it's worth the little bit of radiation to get a really good study.
Thank you very much. Another questions from Boris Muskamimov. What do you think, Steve, about conversion?
What's that?
Don't worry.
My dog had to go out to the bathroom.
Yeah, that's all.
It's important. So I don't think of conversion as a complication. I think you do what's best and safest for the child. And I also think that if you're starting to do these and you get about halfway through the case and it's either taking too long or you feel like you've gotten to a point where you just can't progress, that you should convert to open. I don't, but there's a big difference between my experience and almost everybody else's. But you'll learn if you try to do these thoracoscopically, and let's say you work for an hour and then you're just not, you know, you have an incomplete fissure you can't get through, or you're just not comfortable with the anatomy, rather than do something dangerous, you know, convert. Certainly if you get into bleeding that you're worried about, convert. It's not a complication, you know, but every time you put in a scope, every time you attempt to do this, you learn something new. Your technique gets better, your team gets more comfortable, your anesthetist gets more comfortable. So it's not a wasted effort. I would not spend 10 hours doing a thoracoscopic lobectomy. You can't justify that anymore. I mean, that's too long. That's too dangerous for the child. But you can take a bit longer. But again, it's a stepwise progression. So I don't think of converting as a failure. Obviously, you know, I try to do everything I can to not convert. And if a case takes me a bit longer to do it because there's a lot of inflammation, as long as the child's doing well, I'll progress through. But you have to be aware of your own skill set, of the abilities of your anesthetist and your team, and do what's safest for the child.
Thank you very much. Please, Holger.
Steve, a couple of interesting questions in the Zoom chat. First one comes from Cecilia. Steve, how long do you wait after low respiratory tract infection before you embark on surgery?
Yeah, probably we like to wait at least 6 to 8 weeks.
Okay, cool. Technology asked again, what about robot in terms of lung surgery and pulmonary malformations?
You know, there are certainly reports out in the literature. For me, the robot's too big. It's 8mm instruments and 12mm scope. And I'm operating on, you know, even if you wait to a year, a 10-kilo child. And I do all these operations with a 4mm scope, 3mm instruments, maybe a 5mm stapler. Mm-hmm. Bigger children, obviously I'll use a 12mm stapler, but there's not a big advantage for me. And I think it's just too big.
Okay. And here's a beautiful question from our friend Yuri. Fine question. He's asking, have you, Steve, performed resections in patients after fetal procedures, just like pleuroamniotic shunts? What are the features of that performing, and any tips and tricks?
You know, I actually have not.
Okay.
So I can't say. I don't think it would change anything. We have, we did do one case where they'd put in a shunt and it was sitting in the chest and we had to go fish it out, but that was about it.
There's a last question from my side, from Ahmed, a question about the follow-up. And he's asking about general follow-up, like what do you do, CT scan and lung function. And I would like to come back to your beautiful presentation about the segmentectomy specifically. Any recurrence in a different part of the remaining lung, or what do you see?
So follow-up, assuming I do a lobectomy and the disease is limited to one lobe, I see them back 2 weeks post-op. If they're doing well and there's no issues, we're done. They don't get any more studies. They don't get any more x-rays.
Okay.
Segmentectomies, if I feel like I get a CT scan at about 1 year in all those patients to ensure that I did not leave any disease behind. I've only had one patient where there's been a recurrence of disease, but that patient was actually somebody who is the first segment I did. It wasn't completely an anatomic segmentectomy. And I will say, if you do a segmentectomy, it has to be an anatomic segmentectomy. That means you identify the artery, the bronchus that go to that, and that's how you do it. It's not just taking a wedge of tissue. So it's an anatomic segmentectomy. Those are all of our segments. This child, basically, I thought this was going to be a disease in the superior segment of the lower lobe. And it turns out when I got in there, it was the left side. There was no fissure. Okay. So the child just had cysts that were sort of there with some congenital clefts. And so I either did a pneumonectomy or I did sort of a bisegmentectomy where I took the apical segment of the lower lobe, and what I thought was sort of the posterior segment of the upper lobe, tried to leave the rest. And that child did get some cyst formation that we're following. They're not significant or compromising her, but I know that if I go back in, I'm going to have to take the whole lung. So I think you have to determine your treatment based on, in her case, the risk of further surgery is higher than I think the risk of complications from the remaining cysts.
Final question. Ciro, why don't you ask Steve what he thinks about our last question?
Yeah. Steve, I have a question about chest wall deformity. In general, after thoracotomy in the first year of age, you can have long-term morbidity as scoliosis, chest wall deformity, and shoulder problem. In your great experience, did you perform a comparison between long-term morbidity of thoracotomy versus thoracoscopy in patients operated of esophageal atresia, sequestration, or CPAM?
Yeah, so we have, and I skipped a couple of slides. Can I share my screen again for a quick sec?
Yes, please. Go ahead.
All right. So this is an excellent study that was actually done by Benno Ure. And
we cannot see.
You can't see it?
No. Try again.
Oh, sorry. Here you go. There you go. No. Oh, doesn't want to share. All right. Well, yeah. For some reason, doesn't want to share. But anyway, they did a study where they compared thoracoscopy versus thoracotomy. The rate of scoliosis was 54% to 10%. The cosmesis, the Manchester score, was 13.8 versus 7.5. And I don't think there's any question that there is significant morbidity from doing a thoracotomy in infants and children. Let me see, try it again.
Yeah, you can stop sharing and try share again from the beginning.
Okay, there you go. Now can you see?
Yeah.
Okay.
Yeah.
So here's that study. So here's an example. This is a child who had a thoracotomy. Now this was for a TEF, but she came to me for a hernia repair. I didn't do the TEF, but she has not a bad scar. I think most of us would think that's pretty cosmetic, not bad. But if you really look at her closely, she's got a wing scapula and she's got chest wall asymmetry. And so this is a good result, and it's not great. And then this is a kid who came to my chest wall clinic. So he had a CPAM, was taken out through a muscle sparing thoracotomy as an infant, and look at his chest. So there's no question that a I don't care. I was the first one to write on muscle sparing in children. I don't care if you use a muscle sparing technique. I don't care what you do. There's no question that a thoracotomy is going to have greater musculoskeletal deformity than a thoracoscopic procedure. So yes, it's a significant issue. And there are people out there who are deniers and argue that it's not, but any series that's large enough, you look at enough, and you look at multiple surgeons, there's significant morbidity.
Thank you. Always another question from the chat. you can use a ligature or 3 millimeter sealing device in division of bronchus in infant. What do you think?
No, never, never, never. Vessel sealing devices do not seal cartilage.
Okay.
So you either need to clip it, and I think clips are fine, especially in smaller infants. They work fine. I just put one clip on and that's good. You can divide it and suture ligate it, or you can use a stapler, but do not use vessel sealing.
Yes.
Another question.
Well, I apologize. I am going to have to go operate, but I have really enjoyed this morning. Again, if any of you have questions I haven't answered, please feel free to email me or reach out. I'd like to thank Sammy and Alp and Tamir for putting this on, and Holger and Ciro for the excellent moderation. And again, if you'd like to talk more about other lobes or other stuff, I'm always happy to do that. It's a great way to start my day. So you all take care.
Thank you so much, Steve. Actually, questions keep coming, but you have sometimes to operate instead of talking.
Yeah.
Talking is good, but sometimes you need to operate. Everyone has enjoyed this wonderful talk, not only from the experience and tips and tricks, but also the skills of presentation, which is very enjoyable to everyone. Holger and Ciro has made an excellent job in moderation, and we received a very good questions from expert questions actually from the audience. We promised them that we can deliver the questions to Steve so that he can answer, and all of them are asking your permission to watch the recorded session. So I think Steve, you approve that. I
Yes.
would like to say that this was a very good start for our WOFAPS online meetings, a great start, and you stay tuned. You will see a lot of interesting talks, and maybe we'll invite Steve, Ciro, and Holger one more time for another talk. Thank you very much for joining in, and have a wonderful day. Thank you very much.
Thanks to you, Sami. Thanks to you.
Very much, Sammy.
All right. Thanks, guys.
Thank you so
Have a
much.
good day, everybody. Bye-bye.
Thank you so much.
Thank you all.